Hi, everyone. Welcome to our final installment of our Sepsis Denial and Appeal workshop. This is workshop number 3. I'm Denise Wilson. I'm going to be your host and one of your presenters for today. We also have Dr. Hesham Hasabala, Regional Medical Director for Sound Physicians, as our special guest today. Very happy to have him here presenting. And Dr. Kendall Smith, who's our Chief Physician Advisor at PayerWatch. This webinar today is being sponsored by, jointly co-sponsored by both PayerWatch and the Association for Healthcare Denial and Appeal Management. We're going to discuss sepsis current state. So we're going to let Dr. Hasabala talk a little bit about current state of sepsis and then how to appeal when the payer gets it wrong. So Dr. Smith is going to discuss appealing sepsis denials for non-PAR Medicare Advantage payers. We also have Bill Haynes with us today. I didn't have time to get his information on the slide. He kind of joined us last minute, so thanks, Bill, for coming on. He's our legal director of the clinical legal unit at PayerWatch and also our managing attorney. And then I'll be talking about how to appeal for sepsis-free when the payer gets it wrong and how to appeal inpatient admission denials for sepsis. September is Sepsis Awareness Month, and so in recognition of that, we have joined forces to present these 3 sepsis denial and appeal workshops. Sepsis is a leading cause of death in U.S. hospitals, and the lack of a consistent definition and treatment between providers and commercial insurers is both infuriating and dangerous. And I would just encourage you to help support the Sepsis Alliance, and you can learn more at sepsis.org. Now, you can download the slides for today's presentation straight out of GoToWebinar. You should have a small control panel that popped up when you signed on. Sometimes it minimizes itself. Look for a little red arrow. You can open that control panel back up, and there is a section called Handouts. Go to the Handouts link, and you should be able to download the slides directly from there. Also, we will be taking questions from the attendees today. So if you have questions that you would like any of our panelists today to answer, please go ahead and put those in the questions box. We're planning on going up to and 15 minutes over the hour if necessary to help answer questions. So the attendance at these webinars for sepsis has been fantastic. You guys have submitted a lot of great questions. We've only been able to answer a few during the live webinar, so we will be putting together a Q&A in the next couple of weeks to post. So hopefully you get all of your questions answered. For those of you who are waiting for a response from me, I will do my best to get to you in the next few days. It's been kind of a busy month with webinars today, this month. So Dr. Hasabala comes to us as a Regional Medical Director for Sound Physicians Critical Care Practice in the Midwest, and he knows more than anyone should know about sepsis, and he'll be talking to us about that. Dr. Kendall Smith is our Chief Physician Advisor at PayerWatch, also an advisory board member at the association. And then myself, I'm Senior Vice President of PayerWatch and President of the association, AHDAM. Okay, so Dr. Hasabala, let me give you control, and I'll let you take it from here.
Okay, thank you very much. I'm very happy to be here. Thank you for having me. Very honored to be on this distinguished panel. Wanted to begin with a case study because as an intensivist, we're practicing, I'm currently practicing, in fact, I'm working in the ICU this evening after this. So we see sepsis all the time. It's our number one diagnosis, our number one DRG. So I have a case of a patient who was finishing up the last round of chemotherapy for B-cell lymphoma. Started developing fever and diarrhea for a week. Despite good antibiotic therapy, the fever and diarrhea continued to work, continued to be persistent. A lot of abdominal pain. Very difficult on the patient. And then suddenly, one morning became more tachypnic, more tachycardic, a little bit less responsive, started to develop renal failure, had to go on non-invasive mechanical ventilation, became more and more hypotensive, required more and more support. By the end of the night, had to be transferred to another hospital for continuous dialysis. Had to be intubated to placed on invasive mechanical ventilation. After transfer to the other facility, we got follow-up. Continued to worsen, got worsening shock, and ended up passing away the following morning after about 24 hours. That is what sepsis is. That patient was my daughter. She was 12 years old. She had B-cell lymphoma. The last round of chemotherapy, just everything went wrong. She got an abdominal infection that progressed to gram-negative septic shock, and she passed away. So as an intensivist, I see sepsis cases like this, not pediatric cases. I'm an adult intensivist, but we see cases like this all the time. In fact, I had a case like this probably last night when I was on call. And as a father, I saw it firsthand take my daughter's life. So this is I live and breathe literally sepsis and septic shock. The problem is, how do you define sepsis, right? What is it? It's not like pornography where you know it when you see it. It's not necessarily the case, right? So sepsis, I can tell you, I've had people that died with multi-organ failure from septic shock who presented with rapid atrial fibrillation, right? So sepsis doesn't always, patients don't come into the emergency department saying, I have sepsis. They come in saying, I'm weak, I'm tired, I have abdominal pain, my legs hurt, I'm dizzy. They come altered mental status. So we in the clinical community and the academic community have initially defined sepsis as systemic inflammatory response, which is fever, tachycardia, high white count, a little bit elevated lactic acid, plus an infection. That's sepsis, right? But really, as an intensivist, seeing patients in the ICU, that really isn't sepsis. So if I had a resident or student call me up and say, hey doc, I have the flu and I'm a little tachycardic, my heart was 105, I was 101 fever this morning, so because I'm septic, I'm not going to come into work. That would not fly with me, because you're not septic. And if somebody calls me from the emergency department and tell me, yeah, I have a patient with a cold who has a fever of 101 and the heart rate is 105, and I think I want them to be in your ICU because they're septic, I would have many choice words about that patient. I would not take up an ICU bed for that patient. So while sepsis 2, the current CMS definition of sepsis, and the old sepsis definition, that's technically sepsis, but it's not really sepsis like what happens to my daughter, what happens to other patients that we see in the ICU who really get organ failure. And you can get systemic inflammatory response by trauma. You can go a scary movie, going to a haunted house. We're in the Halloween season. If you travel north of the Mason-Dixon line, you might have systemic inflammatory response syndrome. So, I mean, that's not sepsis. Sepsis really is organ failure because of the body's dysregulated response, right? So we just got over. We're still in the pandemic, but it's not like the dark days of 2020. You have a patient with COVID who develops renal failure, hypoxic, ARDS, on a ventilator. That's sepsis. You have Legionella pneumonia. I just had a Legionella pneumonia patient, very sick guy. He had shock. He had ARDS, renal failure. He was on dialysis. He survived. That is sepsis, right? When I see sepsis as an intensivist, that's what it is. It's organ failure as a result of an infection. That's sepsis, not fever and high white count with a UTI. That's not sepsis. Fever is the normal response to the body of infection. When you're febrile, you're tachycardic. You might be breathing fast. Your white count may be a little elevated, right? But that's not organ failure, which is what sepsis is. It's organ failure, right? So in 2016, they got together and they did statistics on hundreds of thousands of patients, and they wanted to get a more strict definition, a more more accurate definition about sepsis, and that was sepsis 3. It's an organ failure as a result of a dysregulated host response to infection, right? The side effect of that was that the commercial payers loved it. They had a field day because sepsis 3 is way more strict than sepsis 2. And but CMS is holding me and our hospitals to the old definition of SIRS and infection. And if we're not treating for sepsis, but they get tagged as sepsis, then our sepsis bundle compliance looks bad. So it's very frustrating. Like, what is it? Like, is it 2? Is it 3? And the PayerWatch, we had webinars earlier in the month where different doctors, different clinicians will choose different definitions, right? So what is it? Like, and that's we're still kind of debating that in our community. The treatment is the same. So whether you have sepsis 2, whether you have sepsis 3, my principles are the same. I'm going to be aggressive. I'm going to think about it all the time because, again, patients with sepsis don't come in and say, I'm septic. They come in and have rapid AFib. They come in and they say they're weak, they're tired, they're achy, they have stomach pain, and then they manifest the sepsis, right? So we got to have a high index of suspicion, aggressive resuscitation, prompt antibiotics. Those are the principles. What the definition you're using is immaterial. My principles are the same. I'm treating the patient. I'm not treating the definition. But so the definition is different than the principles of treatment, right? So again, here's a problem. So sepsis 3 has the sequential sepsis-related organ failure assessment score, and if you have a pyelonephritis with rising creatinine, does that discount the renal failure? No. And this is what the payers, they love to do it. So, oh no. So someone has I just wrote a denial, and I had to temper my sarcasm, and because they had a patient with Haemophilus influenza pneumonia and bacteremia, who comes in with hypoxic respiratory failure, renal failure, liver injury, and the auditor says, "Oh no, that's not sepsis. No. The hypoxia was due to the pneumonia. The bilirubin is, oh, he has fatty liver, and the renal failure. Oh no, that's chronic renal." I'm like, that's what they do, right? They're gonna say, "Oh no, that's not sepsis. That's underlying liver disease." And that's not how it goes. So we say, no. I go to the calculator and I put it into the SOFA calculator and I get a score of 3, 4, 5, and then the payers still say, "Oh no, that's not sepsis." Okay, that's a problem, and we have to aggressively push back on that, right? So, and the payers keep moving the goalposts, right? So it's very frustrating when you point out, no. Look, here's the SOFA score. They just don't care. That's even if they respond, right? So what I recommend, go on medcalc.com, get an account, plug it in, and then if you have an account, you can copy the results and paste it right into your denial, paste it right into your H&P or your consult, and say, listen, this patient, if you live by SOFA, you die by SOFA. If they don't meet SOFA, and you know what, I've done a lot of appeals where there is no sepsis. Like, seriously, there is, according to sepsis 3. They have a white count of 12 and a fever of 101 and a UTI, and they're totally fine, and they get better in a couple of days. That's not sepsis, because the SOFA score is what, 1 or 0. Okay, fine, that's no problem. But if they do, they can't say, well, no, that's different. That's not how it works. So pull it up and use it, and then we have to hold them to the same language. If you're going to live by SOFA, you're going to die by SOFA, with all, figuratively speaking. And you know what? I'm sorry, clinicians today, we have to be more sophisticated. Gone are the days of when I say, well, I think this is sepsis. And I was like, well, of course, whatever you say, doctor. That's gone, okay? There is no more, although there's a lot of us who still have it, what I call eminence-based medicine. That's long gone. Okay, there's evidence-based medicine. Like, just because I think it's, as an intensivist and pulmonologist and whatever, if I think it's sepsis, that doesn't mean it is. If I think they have heart disease, that doesn't mean that there is. I have to justify my clinical thinking with evidence in the record, right? Okay, it's not just alternative facts, it's facts in the medical record. So those days are gone. You have to look at and you know what? I'm sorry. Until everybody agrees, we're going to have to open up the face sheet on the computer and take a look and see, what does this patient have? Is this a traditional Medicare patient? Then I'm dealing with sepsis 2. Is this a commercial payer? More than likely, I'm going to deal with sepsis 3. That is the way it is. Okay, we can rail about it and cry about it and complain about it. The reality is that we have to be more sophisticated and look at the face sheet and understand, because it's a different world today. It's a different world today. And now, Dr. Smith had a wonderful thing. Okay, so I see a wonderful comment. We had a conversation before our webinar. Okay, I have a patient comes into the ER, right? They're a little obtunded, they're a little altered mental status, a little hypotensive, and I'm aggressive. I give antibiotics right away. I treat them. I resuscitate them. My nickname is in the ICU is Dr. Hasabolus, because I give tons of fluid boluses. So I give them tons of fluid, and they, we had a young woman with sepsis from urinary tract infection. We gave her 6 liters. She's on a little bit of norepinephrine, but by the next day, she's better. She doesn't have renal failure. She's more than awake, and then she goes out of the ICU the next day. We don't get credit for that, right? We don't get credit. There's no, she could have, and I'm not going to wait for organ failure, right? I'm not going to say, well, right now she doesn't have organ failure, but later I'm just going to wait until she develops renal failure. We're never going to do that. I mean, no clinician with the right moral compass would ever wait and let a patient develop renal failure or organ failure before aggressively resuscitating. We got to be aggressive. So there are times where we do the right things and they get better and they're discharged in a day or two, and then the payer comes back and says, well, that's not sepsis. Yeah, but you didn't see what they looked like when I first saw the patient, right? And that's going to happen, and that's why we became physicians and APPs and nurses, and respiratory therapists. This is why we became clinicians, to take care of people. And if I don't get credit for doing a good job and saving a patient from going to organ failure, so be it, right? We don't get credit for being good clinicians, but myself, knowing that I helped that patient prevent going into septic shock, that's why I became a doctor. That's why I'm in healthcare. And there are going to be myriad patients, we saw them with COVID, who, despite everything we do, are going to develop multi-organ failure, just like my daughter. They did everything right. She still developed septic shock. So there are going to be patients like that. And so we don't get credit for being good clinicians. Oh, well, I know that I did right by my patient, and that's all that matters.
AHDAM, quick question. How do you account for patients whose baseline physiology may not be normal? So we're looking at a hypertensive patient who normally is walking around untreated blood pressure of 220 over 140, suddenly shows up in your ER with a blood pressure of 110 over 60, doesn't meet the mean arterial pressure less than 70 score, but obviously is pretty much borderline shock compared to their normal value. Is that something you give consideration to?
Absolutely. Yeah, there's no doubt about that. And I think that's something that I wish more of us had. I mean, if I had that information, it would definitely influence how I manage a patient. You're exactly right. If somebody who normally walks around with a pressure of 180 comes in with a pressure of 90, that patient is probably in shock for that patient. You're absolutely right. Even if they're, if they have a lactic acid of 5.8, which in the new definition is not septic shock, but really somebody who comes in with a lactic acid who has an pneumonia, and they're not hypotensive, but their lactic acid is 6, and then it goes up to 9, then it goes to 12, and they're normotensive the entire time. That patient clearly is hypoperfusing, right? So that's where being a clinician is all about, right? Knowing that information, and that would be great, very helpful. Unfortunately, we don't have that information. Frequently, we don't have that information, and that's the problem. But that kind of history and context is exceedingly valuable.
But my experience has been, even when you do have that history and context and able to bring it to the insurer's attention, is it's really set aside or discounted. It seems not to matter.
Of course, because they're looking at the retrospectoscope all the time, and I've told this on peer-to-peers all the time. I go, listen, this is retrospective. I mean, it's not fair. Well, yeah, it's the way it is, right? They're just like, yeah. You know, you're looking in the rear view mirror, but at the time I saw the patient, this is what I was thinking of, right? And you know what the problem is? Unfortunately, a lot of my colleagues don't document. They don't document. They just say, well, you know, UTI, fluid, antibiotics, and get it over with. They don't document. Document. Tell me why this patient looked. Why were you so worried about this patient? Well, because when I'm looking at them, everything looks great. Blood pressure looks fine. Labs are okay. Everything looks great. What is it about this patient that you saw that made you worried enough to do X, Y, Z? A lot of our colleagues don't document, and I don't know. I can't read your brain. Write it down. Dictate it.
Over and over again, in looking at medical records and writing appeals, I think the death knell, a lot of these cases that are borderline that you could probably argue is the appearance of the magic word stable. That pops up at the end of the ER visit. The patient is viewed as stable, and you look at stable, and they're on Levophed, or they've gotten four liters of fluids, but they're now, quote, stable. They may be stable with respect to what was going on, but that to me has also been a death knell to a lot of these cases over and over. And language, especially subjective language, can be so powerful in appeals.
No, absolutely. When we say stable, so let me give you a window. Okay, so if they're saying stable, my guess is that there's meaning that they're not going to code, that they're not going to code from the ER to the ICU.
Right.
So that's stable. But if somebody is on multiple vasopressors, they're not stable. Okay. But when they say stable for transfer, that means that I don't think that they're going to die between the emergency department and the intensive care unit. So you're right about that. So so when we say stable, I'm comfortable enough to move the patient without having them arrest.
You and I know what that means, and in all likelihood, the medical director on the other end of the phone knows what it means, but they too often play cute with it and point to it.
Again, it's because it's the way they can, well, look, all the criteria. And then when you go and you point that they have other criteria, they say, well, that's just a guideline. It's very frustrating. I mean, it's very frustrating. Like when I win by the guidelines, it's just a guideline. But then when they deny, well, so they didn't make the guideline. I can't stand how they talk out of both sides of their mouth. I really do. It's very frustrating.
Yeah, I agree.
Okay, next up, Dr. Smith, you've got some good things you want to share with us as well. I think you have control of the slides now.
Do I?
I think so. Try it and see.
Let's see. Go backwards. So one of the things that we'll often argue, because the goal in the appeals that we write are to get these outside of the court of the payer's opinion, get them to a neutral arbitrator, a third party that may not be so rigid in their interpretation. I'm a big proponent of looking through the medical record, through labs particularly, looking for labs indicating severe inflammation or infection, procalcitonin, even though it's not considered in SOFA criteria. To the extent that it's elevated, it's helpful to suggest a severe bacterial infection. You know, there's a lot of things in research. Tumor necrosis factors, 10, 20 years ago, were thought to be the cure to sepsis if we could have tumor necrosis factor blockers, but those failed miserably. But there's plenty of inflammatory markers that intensivists will often measure that become part of the record, not considered in the SOFA score, but you may want to add to an appeal with an eye to getting this appeal to a third party for an independent review. That may be the language that sways them. I mean, do you have any thought with that, Hashem?
I mean, I think a procalcitonin, it's fraught. It depends on the patient. I mean,
Yeah.
like for example, very, very high procalcitonins almost always is gram-negative bacteremia. I think almost every time I've had a high procalcitonin, very high, 50, 100, they're gram-negative bacteremia. So that might be supportive, but same thing with ESR, but they're very non-specific is the thing.
Yeah, they're
So,
very
and,
specific.
but it might, you're right. I think that's a very valid point. It just tells you a story that, wow, this patient is really inflamed, but
Yeah, and
that
they're very
doesn't
patient
mean that
specific.
they have organ failure. That's the thing about sepsis, is that it's organ failure, organ dysfunction because of infection. This just tells me that they're inflamed.
And
Does the inflammation then lead to organ dysfunction? That's the question.
one of the questions we get asked over and over again then are, you know, there's a sort of a large organ it's not necessarily considered in a SOFA score, and that is the heart and the value of troponins. And is there a value in looking at troponin scores, type 2 or type 1 on ST elevation MIs, and adding that to the SOFA score? Does that
I
have
mean,
any?
that's a very good point. I don't know if they're going to do that. I mean, there's a lot of research that went into the SOFA. If you read the paper, there's 2 papers in 2016 where they went through what they did, the statistics that they went through to pick these 5 or 6 things. That's a very good point. I'm not sure that if they're going to update it, but that's a really good point. But you're right. A troponin level is evidence of organ damage, and if you have organ damage because of an infection, you have viral myocarditis. If you have a viral myocarditis and you get a troponin of 4, that's sepsis, right? You have an infection and you have organ damage. So that's a good point. I don't know if they're going to do that.
Perfect. One of the things we'll often point out that SOFA Sepsis 3 isn't universally recognized. American College of Emergency Physicians, the ID Society of America aren't necessarily totally on board with using SOFA scores and SEP 3 for a definition of sepsis. We bring that up in our appeals again with the idea getting this to a third party to realize that there is some portion of the medical community that is supportive of the idea of SEP3, but it's not universally accepted. And it's not the slam dunk that the payers want to make it. And it certainly was never intended as a definition of sepsis. And we point that out in our appeals and have had, I think, some good luck once we do get those outside of the insurer's hands into a third party reviewer by bringing that information forward. One of the biggest things and biggest treats that we saved for last is information that Bill Haynes is going to provide. He's our lead attorney, and probably, and you mentioned early on, Hesham, looking at the face sheet. One of the major determinants from the face sheet in writing appeals is to realize whether you're contracted or par, or non-contracted or non-par with that insurer. So if you're getting an audit from someone, for example, Cotivity on behalf of United, saying that we are denying this case for sepsis because United has a policy that they define sepsis according to a SOFA score and SEP3 criteria, it turns out that as a non-par or non-contracted provider, you have a whole set of rights that are set forth under Title 42 of federal code that Bill's going to go into, dealing with that appeal. More often than not, it's not set forward in that denial letter, nor does the denial letter indicate that you're not participating with that insurer. So I'm going to turn it over to Bill here to comment on this. And this is definitely a little pot of gold for the end of this series.
Thank you, Kendall. Yeah, so the listed here are the sources for where this right and the details of the entire process. We're going to be taking a very general look at it right now, but if you want the details, the steps are laid out in Title 42 all the way down subpart M of those sections and subchapters, et cetera, of Title 42. And then if you want a very detailed description of every step of the way and all of the little nuances, that's laid out in this particular CMS guidance that's listed here. That's also where we discover, they don't list it up front, it's in a footnote, I think somewhere maybe like a third of the way in, where CMS mentions, by the way, if you're contracted with a payer, none of this applies and you only have your contract. That's why it's so important that you know your contract status when you're doing an appeal, because this whole set of appeals, this appeal process that I'm about to go over, if you're contracted, you don't have any of it. It disappears. But if you're not contracted, you have this process and you need to know about it because, as we're going to see, payers have not been very good about mentioning it. So Kendall, if you could go to the next slide.
Sure.
Okay, so again, this is a very, this is just an overview of the steps. The sources I mentioned before will have more details about the timing and about what's involved in each process. But you start with the organization determination. That's the payer saying whether or not they're going to actually cover it. That's their yes, we're going to pay it, or their denial. And then you can appeal that in what's called a health plan reconsideration. If they uphold it, then they automatically have to send it to an independent review entity for an IRE reconsideration. If the IRE upholds it, then you have the option of going to a hearing in front of an administrative law judge. If they find against you, you could then go to the Medicare Appeals Council. You accidentally went ahead, Kendall. Can you go back? No problem. And that's the end of the bureaucratic process inside CMS. You can then take that final decision into federal district court and potentially all the way up to the Supreme Court. And as mentioned here, the first three levels, the original termination and the reconsiderations, those can be expedited if that's warranted by the medical facts of the patient. Okay,
Bill, I'm putting you on the spot with a question, and I know this isn't fair, but I'm notorious for doing this.
Yeah.
As to whether cases could be bundled going into federal district court, or do they have to be taken and considered individually, as the circumstances for each case would be unique?
You would probably have to do that one decision at a time. Because the end result from the Medicare Appeals Council, that's going to be one final decision. As far as I know, they're generally not making decisions based on sets of cases. They're making decisions, these are bureaucratic decisions on individual cases. So an individual case would have to be taken into federal district court. However, if it's a good case, and if it goes higher up in the court system and sets a good precedent, that could then be used. The interaction between legal precedent and administrative law is more complex than I'm willing to go into right now. So there could be value in taking a particularly good case into the federal court system. But generally, you're only going to be taking in one decision at a time.
Okay.
Okay, so the reason you might not have heard about this process is that payers have actually been very bad at telling providers about this process when they are supposed to. And it got to the point where in 2020, CMS actually had to send out a reminder memo to all of their MA organizations, reminding them that this process, and they have the truncated reference here, 42 CFR 422M, applies to all non-contracted providers who furnish services to an enrollee, that they have the option of requesting a reconsideration. And that means, and that goes up through the entire process. And if you go to the next slide, and they mentioned specifically they had to do this because they received information that MAOs are not always providing the information on this process particularly after revising an organization determination. If they revise an organization determination, most of the time, the vast majority of the time, that's considered a new determination. And that gives you a new separate right to appeal. So I strongly recommend, if you're interested in pursuing this process, here's the link to this memo that they sent out. I strongly recommend reading it. It's not too long, but it gives you a very good idea. It clearly lays out what the issue is, and they do give some examples of what is or is not an organization determination. And it is much broader than what payers have been suggesting. So this is an important piece to know about. And if you're not contracted with the payer, you are entitled to this whether or not they mention it. And it's something, again, we have found that once you go outside of the payer's process, you're much more likely to succeed.
And on behalf of a system that we handle appeals for, we came across a large bunch of denials for a particular payer where this wasn't mentioned, and reached out to their chief legal counsel, put them on notice that we felt that this had been short-circuited, and within 30 minutes had an email back from chief legal counsel asking us to send the cases over so that they could re-review them.
Yes, and in that case, it was important. I'm going to mention here, I'm very happy that Dr. Hasabala mentioned the importance of documentation. Documentation, particularly at the point where you're treating the patient, is so important because that sets the record that is going to go before these other people. Going in front of a third party, that helps. You're going in front of a party that doesn't have the same interests as the payer, but they can only act on the record you give them. And if you don't give them a good record, you can't expect a good response. In the situation Kendall was talking about, these were denials that were denied for billing validation purposes. And billing validation is not considered an organization determination. It's not subject to this appeals process. However, when you read their billing validation, they were giving medical necessity reasons for the billing validation. You can't just call a medical denial billing validation and say that that's fine, and then act like it's not an organization determination and that the appeal process then doesn't exist. That is, that's pretending that a medical denial is something other than what it is. So this is something we've seen. It's not just that the payers are denying medical necessity and forgetting to not mention this or intentionally not mentioning it. They may be classifying these denials in ways that they know and you may know aren't subject to appeal, but then if you look at the facts of the record, it's actually something you should be able to appeal.
Okay, and we also have done webinars in the past on those topics, and you can find those, watch those on the AHDAM.org website. Those are free, as well as the PayerWatch website. So thank you, Kendall and Bill. So I'm going to talk a little bit how to appeal Step 3 when you actually have Step 3 in the medical record and the payer still denies it, and then also talk about how to appeal an admission for sepsis. But I kind of like this slide. I wanted to put this in here. This was published about a year after Step 3 came out. It was in the I think it was in JAMA. It doesn't say that here, I don't think, but I think that's where it was originally posted. Someone had written kind of an opinion piece about Dear Sepsis 3. We're sorry to say that we don't like you. And I think it kind of summarizes some of the issues that we've been talking about between Step 2 and Step 3, that the Step 3 criteria introduces no changes to the approach to sepsis, which Dr. Hasabala talked to us about, antibiotic treatment, fluid therapy, vasopressor. But what it does do, Step 3, is does neglect the early identification of sepsis before the development of organ failure. And Dr. Hasabala, you covered that very well as you were presenting your discussion. So some of the trends that we're seeing in auditing denials and appeals. So many sepsis denials are being issued by third-party contractors like Kendall, Dr. Smith mentioned, Cotivity, and others are doing a lot of the auditing, and most are using, but they might not be specifically quoting or citing the SEP3 criteria. So I haven't seen a denial for the sepsis in a long time that didn't at least allude to the SEP3 criteria. So it's almost always denial language is always going to include talking about that evidence of acute organ dysfunction. Sometimes they use SOFA scores in their denials, but without any specific citing of SOFA criteria, which makes it a little bit difficult to understand why they are issuing a denial. There's wide variation in the quality and consistency of the documentation we get for denial rationales from the payers. And sometimes they read more like coding denials and don't even reference clinical criteria. So that can make it confusing as well, because of course they can deny for the coding of the sepsis as well as for the clinical validation of the sepsis. So sometimes trying to figure out what the payer is actually saying is a challenge. So let me go through a case study this was for clinical validation, where the patient met step 3, but the payer denied it anyway. And I'll invite Dr. Hasabal or Dr. Smith to chime in if you have any comments about the clinical states of these patients. So here's what the payer said they saw. It's a 56-year-old female with diarrhea, positive for C. diff, treated with antibiotics. And what the payer said was there are no indicators of an organism's homeostasis being challenged by the effects of an infection, including one of the things they had listed there was altered mental status from baseline. So they wanted to remove the sepsis diagnosis. So what was documented in the medical record was that the patient presented to the ED with altered mental status. So I know you guys see this all the time. They say, well, they didn't have altered mental status, so we're going to take sepsis off of there. Well, it's documented in the record. Yes, they did. The patient woke up confused with vomiting and diarrhea. The physician stated that the patient was awake, confused, did not answer questions, and her daughter said, well, at baseline, she has difficulty with short-term memory, but she is conversational and cooperative. The physician documented meets criteria for sepsis on the basis of the elevated white blood cell count and the tachycardia, the 106, with source most likely colitis. But he did not, in the medical record, draw a clear connection between the altered mental status and sepsis. When he says meets criteria for sepsis, he just mentions the WBC and the heart rate. Okay, so he didn't directly connect the two in his documentation. So here's how we appealed it. What we do for clinical validation is a lot of times we will copy and paste exactly how it's written in the medical record because that's what the payer is looking for. How was it documented in the record? So in the ED provider note was basically that note that I just read to you about the patient having altered mental status, vomiting, and diarrhea. Then in the history and physical, the attending physician writes meets criteria for sepsis based on the WBC, the heart rate, and the colitis. So point of discussion here, there was no link to the altered mental status. So does the patient have organ dysfunction? Do they have SEP3? And we went ahead, we appealed it, we got this one overturned, and the way we appealed it is we talked about, the fever, the tachycardia, the tachypnea, the WBCs, and then the appeal writer also placed in the appeal letter about the creatinine being elevated. However, the patient has chronic kidney disease. Now, I would not have, unless I have evidence that this is, unless the physician has documented kidney, acute on chronic kidney failure or something about, concern for kidney dysfunction, I would not have included that in here because I want to keep it clear. I don't want to muddy up the argument as far as does this elevated creatinine represent organ dysfunction from the sepsis, or is this her typical creatinine numbers because she has chronic kidney disease? So thoughts about that, Dr. Hasselbauer or Dr. Smith?
I mean, that depends on what's the baseline. So if the baseline is 1.8, and that's what I like about SOFA, because it takes into account chronic disease, right? So I think I'm comfortable assuming that all of us on this panel and Bill have a SOFA score of 0 right now. We're, thank God, healthy. Now, if somebody comes in and their baseline SOFA score is 5, and then we measure it when we evaluate them and they have an infection and their SOFA score is now 8, that's meets criteria for sepsis. What they were trying to do with SOFA is to capture not only people coming from the community who are healthy or maybe not healthy, but also in the hospital, because we miss a lot. It's very easy to miss sepsis when you're already in the hospital. If you have somebody with cirrhosis, right, or they have kidney failure already, and then they become septic, those are more difficult to parse out. I can't tell you how many COVID patients ended up dying from sepsis. They came in with COVID, they're vented, they've been on the vent for weeks, and then they develop sepsis. So that patient may have a SOFA score of 12, and then their SOFA score then becomes 20 from an infection. That's sepsis. So that's what the SOFA score is trying to do. So it depends on if the baseline creatinine was 1.2, right, or 1.4, and they come in with a creatinine of 2.86, and they're altered, and they have C. diff colitis, I would go into the calculator if it's a commercial payer and say, listen, your score here is 3, and they have C. diff colitis. Done. I would not say WBC, or because that's, again, if you got I just had my COVID booster, and I think I had a fever last night. That's not sepsis. That's systemic inflammation, right? So fever, leukocytosis, to me, is just evidence of an inflammatory response to something. But kidney failure, altered mental status, the problem, and another thing is we don't put the Glasgow Coma scale a lot. That'll be very helpful.
Exactly.
Just fill in. I mean, again, all this on calculators. So just fill in the Glasgow Coma scale, because that's what they're going to point to. You're going to say altered. What does that mean? Unfortunately, the SOFA has a hard criteria of the Glasgow Coma scale. If we just put that in, that'll really strengthen the case in the documentation.
Right. Yeah, I agree with you.
The patients that come into the emergency room that are new to the system, where they say, well, I have cirrhosis and I have chronic kidney disease with no baseline labs. You get a creatinine of 3, you get a bilirubin of 4, no idea what the baseline is. And the benefit of the doubt is that you're going to give them full credit for those abnormalities until proven otherwise.
100%. I mean, it's not like Milliman, which wants you to have 3 times baseline, right? And that's another fight that I have all the time with payers about Milliman. And well, it's not 3 times baseline; it's 2.7 times baseline. So, but no, I would give full credit. Somebody comes in with a bilirubin of 4 and a creatinine of 3, and I don't know what they were before. Yeah. And they come in with C. diff, or they come in with pneumonia, UTI, or COVID, or flu, or whatever. Yeah, man. And you know what? It very well could be from dehydration. To be honest, they might just be dehydrated, but why are they dehydrated? Not because they stopped drinking because they just didn't want to drink. No, they're dehydrated because they're sick.
And
because they have an infection.
Colitis, massive.
Or they have diarrhea. Yeah, they have massive diarrhea. And they're in renal failure because of the diarrhea, right? So it's all connected. They like to separate. Right. Well, that's from the pneumonia, that's from the colitis, but it's all one, right? They have what is pneumonia? It's an infection, right? What is colitis? Right. Bacterial colitis. It's an infection. You know what I'm saying? So we can't let them do that. Like we just can't. You can't have it. You cannot be Marie Antoinette. Okay, can't do it. All right, you gotta. If it's one definition, it's one definition.
They're gonna say the same. Like to unmake the cake and say, well, there were 2 whole eggs over here, and et cetera, et cetera.
I love that. I love that analogy. You cannot unmake the cake. It's all in.
Right.
But the cake that they're serving us tastes horrific. by the way.
So in this appeal, the way, because again, not one, if the physician in the documentation does not connect the dots and pull it all together and say that the altered mental status is part of, why he diagnosed with sepsis, then in the appeal, I don't like to kind of step over that line and say that, but you can still say it in a way to say that she presented with altered mental status, fever, leukocytosis, tachycardia, C. diff, colitis, all of which were consistent with the diagnosis of sepsis. So I'm not saying that, that she met step 3, or that the physician, or that the altered mental status was the organ dysfunction that supports the step 3, because the physician didn't pull it together. So I just want to point that out. You could still say it in your appeal. There's nothing that says you can't connect the dots in the appeal. Just be careful about how you word it. That would be my advice, to not kind of step over that line and be the person who, because you're not the physician, you're not the one diagnosing the patient that pulls it all together, if that makes sense.
Well, I mean, if you're going to use sepsis 2, altered mental status is a SIRS criteria. It's not just fever, there's a whole list that's this long of SIRS criteria. I'm sorry to interrupt, Denise, but altered mental status is one of the SIRS criteria. So yeah, man, do it. Sorry.
Okay, that's all right. So let's talk about sepsis admission denials. And the vast majority of what we see is the patients come in with obviously they got something else going on, like you said, they've got pneumonia or something else that has brought them into the hospital, and yes, they've also have sepsis. So what we see a lot of times is the payers are going to use their criteria for that, whatever the infection is or the issue is, the medical condition that they think the patient was brought into the hospital for, and they tend to just ignore the sepsis. So they're not really screening for the need for the inpatient admission based on the sepsis diagnosis. They're screening based on one of the other diagnoses. So this was a 69-year-old lady who came in with a history of asthma. She was short of breath and wheezing for 3 days. She was afebrile with stable vital signs, normal oxygen saturation. This is what the payer is saying. Temperature of 98.1, pulse of 71, respiratory rate of 20. So that's what they saw. What they said was treated with IV steroids and nebulizers, discharge after a 2-day stay. It was actually a 3-day stay, so that was wrong. Received outpatient observation services based on Medicare definition. This was a managed Medicare plan. Also, there was no peak respiratory flow, less than 40%, no hypoxemia, no hypercapnia, cyanosis, dysrhythmia, altered mental status, or imaging abnormalities. So I don't know about you, but I've never seen that outlined in Medicare's observation definition, that they have to have all of that in order to be in observation. So obviously they're using some kind of screening criteria. They're not using Medicare definitions of inpatient. So what was documented in the medical record? 69-year-old asthma, worsening shortness of breath, fever. She did have a fever and wheezing. She'd been suffering for 3 days, and despite compliance with breathing treatments, her symptoms continued to worsen. So she's failed her outpatient care. So she presented to the hospital for further evaluation and care. She was febrile. She was tachypnic. She was tachycardic. She was hypertensive. She was ill appearing. I was happy to see those words in the medical record. With expiratory wheezing, she had an elevated glucose, procalcitonin, BUN, and creatinine levels, and the sepsis protocol was initiated. And then in the history and physical, they mentioned the sepsis secondary to human metapneumovirus, acute kidney injury, and mild persistent asthma. So it appears to me the payer was screening this based on asthma, when actually her asthma was not the gist of the treatment of her while she was admitted. Okay, yeah, she was having a mild, asthma exacerbation, but that was not really why they admitted her to the hospital. So the plan of care was that she was ill appearing. They would admit her. They spelled out their clinical indicators of infection and sepsis, the fever, the heart rate, the respiratory rate. Patient started on vancomycin and ED, and blood cultures are pending. We'll check a procalcitonin level. So that was pretty good documentation of the reason for the admission. Okay, especially having in there that the ill appearing, they were going to treat her for sepsis. I think that was a pretty good justification for the admission, and this one we did actually get overturned as well. Okay, and this is this is just one paragraph. It's about a 3-paragraph appeal letter, but this is just a summary where we talk about the failed outpatient therapy, the septic suffering acute kidney injury, and how she had a high risk for progression to severe sepsis, organ failure, and even death. And so the treating providers clearly intended an elevated level of care and monitoring for this lady. We also include evidence-based guidelines, evidence-based medicine, as Dr. Hassanbala spoke of, in our appeal. So we have this templated in to our sepsis appeal letter, and then we can go through and kind of bold the statements within these evidence-based guidelines that help support the need for the inpatient admission. Okay, so these are the two that we use for this particular appeal. Okay, so some takeaways from at least my portion of the presentation today include organ dysfunction when it's present in your clinical validation appeals. For your inpatient admissions, the emphasis on the sepsis diagnosis and treatment. Understand and search out the clinical indicators outlined in the SEP 3 manuscript. Does the patient look sick? Please, let's talk about how sick the patient is. Where's the evidence of systemic response to infection and the organ dysfunction? And don't be afraid to argue SIRS plus infection, which we do a lot of times, Dr. Hassanbala, for our cases where, you know, it's being diagnosed as using SEP 2 criteria, because we still have a lot of physicians out there and hospitals out there that still use that as their criteria to diagnose sepsis. Let's go the other way.
I would say most still do. I would say most still do. I think, again, because for us, it doesn't matter. That point that you mentioned in that article is a good point. I mean, it doesn't, the criteria is just trying to define, especially for, they also mentioned when you read the paper, they're talking about clinical trials. How do you, I mean, if you're going to do a sepsis clinical trial, you need a definition. How are you going to enroll patients into the study if your definition is nebulous? And so, and they found that a lot of people with SIRS were not actually septic, which was what I filed. A lot of people who meet SIRS criteria are not necessarily septic. So the new definitions was trying not just to change it and make it more real what it is, but also when you're doing clinical trials on sepsis and septic shock, you need a definition to enroll a patient. And so, but most of, again, it doesn't matter to me what the definition, if I'm worried that this patient is septic, I'm going to treat them, the definition notwithstanding.
Okay, I know we're right at the top of the hour, and some of you are going to probably need to jump off because you have other commitments. We're going to stay on for a few minutes and answer some questions, so you're welcome to stay with us as we go through some of the questions you all have submitted. All right, so this question says, would you address to United Healthcare stating SOFA criteria needs to be applied after fluid resuscitation? And if lactate or creatinine improve, then it's disallowed.
That's ridiculous. That's ridiculous, because, and that's another way of moving the goalposts, because now they recognize that they can't win because the patient comes in sick, and so, oh no, they have to have organ after you try to. That's ridiculous. That's totally ridiculous, because most of the time, first of all, lactic is not even in the SOFA criteria for good reason, because you can have a high lactic from anything, right? PE, colitis, dehydration, running a marathon in the summer. I mean, there's so, when I ran the marathon in 2010, I'm sure my lactic acid was very high, Oh, my legs were burning. My lactic acid was super high at the end of the race. I wasn't septic, thank God. So that is ridiculous. And another way of just changing the goalpost because you can't, because they don't want to die on SOFA. That doesn't surprise me, but it just makes me very upset.
Can I jump in here for a moment?
Sure.
So this is something we've come across. Let me also take a moment to mention here, since I forgot to mention it before, I'm not your attorney, this isn't legal advice, but we've come across this moving the goalposts idea. This is something that you can argue against because oftentimes, you may have a contract or the payer, Medicare Advantage payers do have an option under the guidelines to use third-party criteria and this sort of thing, and they'll say that's why they can do this. If you're setting a standard, you have an obligation to follow that standard honestly. And you can argue back when they say, okay, here's the standard, and then they just don't follow it. That's not honest. And you can present an argument to third parties saying they are the ones setting the standard and then not abiding by it when we have evidence that we meet that standard. So we
do that
see
all the time, Bill. They do it all the time, even on the phone. Oh, it's just a guideline, Milliman. Oh, it's just a guideline. When I go and point out, look, this criteria is met, this criteria is met, this criteria is met, and I'll copy and paste the criteria in the letter. It's just a guideline.
Yeah, and that's something to keep in mind for appeals. If you are being held to a standard, you're allowed to say this, we agreed to this standard, or you are holding us to this standard, and we have evidence that we meet the standard. You're being dishonest in denying it or just picking and choosing what now applies to the standard, even though, like Sepsis 3, my understanding is that it's laid out what the standard is. They can't then go back and say, okay, but now the standard excludes this. Now the standard excludes that. Well, this is the standard you said you have to meet. So you're being dishonest if you're saying this is the standard, oh, but now it isn't.
And those are cases that we'll take to the State Department of Insurance, we'll send to the CMS.gov or the OIG. Yeah. If you can get a bunch of them and bundle them up and send them to the OIG for CMS, this is fraudulent behavior. You're being there have to be held to some set of rules, and if they're making up rules on the fly and denying, there's got to be accountability for this. And CMS has a great interest right now in monitoring Medicare Advantage programs, especially through the risk-adjusted comorbidity programs, HCCs. In my not my words, but the opinion that there may be some pocketing of the difference between what CMS is paying them and dollars being denied, and that's in essence what's being looked at some levels right now. So, is there financial gamesmanship going on as a result of this? Who knows? But we'll find out, I think, once the OIG gets this out.
We were talking, like, to all the physicians out there who may be listening, we have got to be aligned with the hospitals at which we practice. We're no longer, we can no longer afford to have this adversarial, well, I don't care, I'm just going to do what I want, and we can't do that anymore. If the hospital closes because the margins are just so thin, and in the best case scenario, according to Kaufman and Hall, 2/3 of hospitals are going to lose money in the best case scenario. We've got to. It's a razor thin margin, and we have to understand that our documentation or lack thereof, more often than not, our lack thereof really has a downstream impact that I see as a physician advisor that I understand. But a lot of practicing clinicians, we're so busy, we just want to get through it. But copying and pasting your notes from day to day to day, not explaining why the patient's staying there to 2 more days, why you're not discharging it, why you're uncomfortable, those things that I trust you as a clinician, you got to put it in the record. There's no longer, we just, if the hospital closes, I have nowhere to practice as an intensivist.
And these cases have a two-edged sword because they're incredibly use an incredible intensity of service to take care of these patients, and the potential reimbursement as a result is appropriately very high. So if you're taking care of the patient successfully and your documentation is just poor, and you're not getting the check at the end, you provided this service for free essentially, and the hospital's margins have taken a double hit. They've had to pay for the resources, and now they've gotten zero reimbursement because of the documentation.
And we have to start caring about that. We really have to start caring about that. We can't just say, well, I don't care. Well, if there's no more hospital in the community, that's a huge disservice to not just the practicing clinicians, but to the patients and to the community. Hospital is an employer. And you know what? Throughout the pandemic, guess what? The hospitals were there to take care of people, person after person after person after person after person, that overwhelmed our entire system. And we were always there. And so we have to care as clinicians, because God forbid we have another pandemic, which we very well could likely. If there are no more hospitals, people are going to die.
And I think the appeal writing community is in the unique place of being able to speak up about documentation. So if you're seeing patterns from departments, from physicians, those are things to escalate to your manager, to perhaps have a discussion and an education where they can take a denial from a specific insurer, go to a department meeting, go through the medical documentation, and show what where the failures were and what needs to be improved, because the appeals community serves as the catch-all for all of these things. If charts had great, perfect documentation, they wouldn't be sitting on your desk as a denial.
Exactly.
Okay, another question. The payer stated treatment for sepsis is not the same thing as being diagnosed with sepsis, noting that even though they were initially treated for sepsis while they were being worked up, the workup did not pan out to meet sepsis 3 criteria. So you have any thoughts about treating for sepsis versus diagnosing sepsis?
I would rather treat 100 patients for sepsis and have 100 of them not have it than miss one and have that patient die.
Well, I think too, the key words here are resolved and ruled out. So you can start treatment early with sepsis and interrupt its natural course and document sepsis resolved, versus starting treatment for sepsis empirically, finding that they had a secondary condition that was leading to them appearing septic, and therefore sepsis was ruled out. So those two words and distinctions, I think, are paramount in those cases.
Absolutely. I mean, a myocardial infarction with cardiogenic shock and STEMI and renal failure, that looks exactly like septic shock.
Absolutely.
Right? Exactly. The only difference is no infection. So,
yep.
but I might treat empirically just in case. So I'd much rather treat 100 patients and have them not have sepsis early, because once you lose the leverage on the disease, it's a vicious cycle, and nothing I can do can reverse it. No, once it starts, it's once the horse is out of the barn, very hard to corral that horse back in.
Yeah, and it becomes a forest fire that you just can't get under control.
Exactly. It becomes a forest fire that gets out of control, and then you're burning. It's just too late. So that's the key. The key is early aggressive therapy, early aggressive resuscitation, and you know what? Those are the 2 stays that their insurance comes back and says, well, it didn't meet inpatient criteria. They went home in 2 days because you didn't document how bad they looked in the ER. That's the problem.
They survived to walk home, but if they hadn't survived and they died after 2 days, they would have paid for it. So it's so absurd that you're doing the right thing. You're intervening early. You're saving lives, and then you've got these people that are just retrospectoscoping the heck out of the care you provided and saying, oh, it wasn't necessary.
Well, then it's on us to document how bad this patient looks.
Yep.
You gotta put it in the record how bad they look. And this patient looks really sick. And they are going to die if I don't intervene 1, 2, 3, 4, 5. Put it down that way. They don't do it. It's very
Yeah, and medically, legally, it's good protection for you as, you know, as a
100%.
physician, because you may get that one patient that actually does die on you. And then you've documented up front that, you know, this is not an unexpected outcome. They came in looking like death warmed over. Instead of just writing rule out sepsis, you know, bolus, dopamine, blah, 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 blah. You've at least, you've covered yourself on multiple bases that way.
Yeah, we haven't even talked about medical legal. Yeah, and
Yeah.
just right document. I mean, right now we have EMRs. Right now you can dictate. You can dictate in your phone. You have Dragon. Yeah, it takes me. I dictate my appeal letters 4 minutes, and I have a letter this long by dictation. Come on, guys. There's really no excuse. Just take the extra 30 seconds to write 3 more lines, and it saves a world of pain down the line. I can't say it enough. It's gonna be my next newsletter on LinkedIn about those short day stays and documentation. Just document, for the love of God, please.
Keep calm.
All right. Well,
keep calm and document.
all right. Well, thank you guys. This has been great. I just love to hear you guys just, you know, speak to your experiences and your recommendations to our attendees, and just really speak from the heart, which both of you do. And thank you, Bill, for joining us kind of last minute to talk a little bit about the legal stuff. Lots of great questions. As I said, we're going to, now that we've done our final of the 3, cull all of our questions together, because obviously we have some similar questions, and put together a document for you all, posted on our websites with a Q&A for all 3 of our webinars today. So thanks everyone for joining us. Thank you, Dr. Hasabala, for being our special guest today.
Much.
Really enjoyed having you, and we'll see you all very soon. Thanks everyone, and
take care. Bye-bye.
Thank you, everybody. Have a good one.